Hello everyone, my name is Karl, previously a PhD student at the Technical University of Munich with Stefan Nicola and Markus Schweiger, now an employee of Siemens Healthcare at King's College London. Today I will present our paper from the upcoming issue of MRM entitled Myocardial Perfusion Quantification using simultaneously acquired ammonia PET and dynamic contrast enhanced MRI in patients at rest and stress. One of the main reasons why we are interested in myocardial perfusion imaging is so-called coronary artery disease, which is one of the most prevalent diseases in the Western world and presents as an obstruction of blood supply to the heart. The integrity of the coronary vascular system may be assessed invasively by angiography, but there may always be a discrepancy between morphology and downstream perfusion, for example due to collateralization. This motivates perfusion imaging. As dimensions of the microvascular architecture escape the spatial resolution of all clinical imaging modalities, we usually observe a voxel average distribution of an injected contrast agent over time, as shown on the right for dynamic contrast-enhanced myocardial perfusion imaging. In addition to the qualitative assessment of myocardial perfusion shown here, absolute quantification of myocardial perfusion may also be desirable for interpatient comparability as well as for cases of balanced ischemia. The established clinical standard for myocardial perfusion quantification at the moment is ammonia PET. With respect to absolute quantification of myocardial perfusion, it was the goal of this study to compare quantification results between dynamic contrast-enhanced MRI and ammonia PET using simultaneously acquired data from integrated PET-MR imaging. The paper has a special focus on the systematic technical differences between the two modalities. One of the two major technical differences between PET and MRI imaging that this paper focuses on is temporal resolution. As shown on the right, MRI usually achieves temporal resolutions on the order of the patient's heart rate, which means it's either 1 second or higher. PET, on the other hand, can only achieve temporal resolutions of 5, 10 to 30 seconds with acceptable SNR. For PET, the fact that its temporal resolution is lower than usual blood transit times implies that quantification of perfusion cannot be based on directly observing vascular tracer transit. Instead, PET assumes a proportionality between blood flow and the extraction rate K1. For DCE MRI, where time resolution is higher or on the order of blood transit times, quantification usually takes into account a dynamic vascular signal. Another important difference with respect to perfusion imaging between PET and MRI is the distribution volume of the agent that is actually used to probe perfusion. For MRI, this is usually a gadolinium-based contrast agent which remains exclusively extracellular, while for PET, the tracers are smaller and may distribute intracellular. For PET, this means that the natural reference volume for perfusion quantification is actually whole blood, which means that the quantification result is usually blood flow, which we denote as FB. For DCE MRI, where gadolinium-based agents remain extracellular, the natural reference volume for conducting the quantification of perfusion is the plasma, which means that the quantification result should be plasma flow, FP, which is smaller than FB by a factor of 1 minus a tissue hematocrit, which represents the average hematocrit in a voxel that contains tissue. Ignoring correct reference volumes during quantification will assume an equality between tissue hematocrit and arterial hematocrit, which is not necessarily true. In this context, it is important to stress that the dependence of blood flow estimates obtained from DCE MRI on microvascular hematocrit and the fact that the MRI signal receives contributions from water in all tissue subspaces are two separate things. With respect to water exchange, violation of the usually assumed fast exchange condition is in fact an additional confounder to the comparability between PET and DCE MRI. This slide shows a schematic depiction of the study design and the patient cohort characteristics. For a total of 29 patients, PET and MRI perfusion data were acquired simultaneously on an integrated 3 Tesla PET MRI scanner, with the adenosine-induced stress scan preceding the scan in resting state. For PET, a 15-minute list mode acquisition was combined with a standard Dixon-based attenuation correction and OSEM and MLAA reconstruction. Perfusion quantification was done using a 3-compartment model incorporating spillover correction. On the MRI side, a prototype saturation recovery flash sequence was used with dual sequence design for separate acquisition of the arterial input function. Additional pre-contrast proton density weighted images and MOLY-T1 maps were acquired for surface call intensity correction and signal nonlinearity correction. For evaluation, perfusion was separately quantified from PET and DCE MRI data and fused in a final step for one midventricular slice per patient. Comparisons between PET and MRI were done on a cohort average, slice average, and regional 6-segment per slice level. Combination of DCE MRI-derived plasma and PET-derived blood flow for microvascular tissue hematocrit estimation was also performed. Post-processing of DCE MRI data featured retrospective motion correction as implemented by the vendor of the scanner. Additionally, surface call intensity correction was performed on the segmented part of the myocardium only, as previously described. Quantification of gadolinium concentration from MRI signal was performed using block equation simulations for both arterial input function and tissue curves. Signal normalizations for these simulations used the combination of pre-bolus MOLY-T1 values and baseline signal from the perfusion sequence. For modeling the deconvolution of arterial input function and tissue curves, 4 different approaches were used. These were model-free singular value decomposition, a 2-region distributed parameter model as previously described, and the widely known Fermi function deconvolution using a constant leakage term to account for contrast agent extravasation. 2 flavors of the Fermi model were implemented and compared. One unconstrained version, and another one with the constraint of having the response function RF smoothly approach 1 and equivalently have the transit time distribution approach 0 at time equals 0. This constraint both reflects the physiological impossibility of instantaneous contrast agent traversal through the vascular space, as well as the fact that DCE MRI deconvolution analysis cannot reconstruct transit time statistics for times shorter than the temporal resolution of the dynamic data itself. Coming to the results section, we'll first look at the cohort average results, which represent an average overall slice average results across all patients. For all 4 models, it can be seen that MRI-derived blood flow results overestimate PET results, especially at rest, if we assume tissue hematocrit being equal to arterial hematocrit. This in turn leads to an underestimation of the myocardial perfusion ratio for MRI when compared to PET. If the observed difference between MRI and PET flow estimates is projected exclusively onto the systematic difference between plasma and blood flow, thereby neglecting all other potential confounders, the obtained estimates of tissue hematocrit were found to be significantly different between rest and stress. When averaged across all DCE MRI modeling approaches, the relative fractions of tissue to arterial hematocrit DHCT of 63 and 89% translated to an average tissue hematocrit of 26% at rest and 37% at stress. For the additional microvascular parameters that are obtainable using the distributed parameter model, the following changes between rest and stress were observed. For the permeability surface area product, a significant increase. For the plasma volume, also a significant increase was observed. For the extravascular extracellular volume, no significant increase was observed. And for the extraction fraction, a significant decrease in response to adenosine stress was observed. The slice average results shown on the right, with one patient being represented by one blue and one green data point for rest and stress respectively, essentially reiterate the described cohort average results. Plots A and B depict correlations between ammonia PET and DCE MRI derived blood flow both under the assumptions of tissue hematocrit equal to 0 on the left and tissue hematocrit equal to arterial hematocrit on the right. The significantly higher MRI blood flow estimates at rest when converted assuming equal arterial and tissue hematocrit can be seen best in the bland outline analysis on the bottom right. The next slide presents a comparison between regional PET and MRI flow results using the previously obtained tissue hematocrit fractions to convert DCE MRI plasma flow to blood flow. Plots in the top row show this comparison in a pooled fashion, individually comparing all 6 segments for each patient for both rest and stress datasets. While SVD in the constrained Fermi approach proved to be most robust in the context of the concomitant decrease in SNR When moving from a slice average to a sector-wise analysis, the most important finding shown here is the significant amount of high flow outliers produced by the standard unconstrained Fermi analysis. Closer examination showed that unconstrained application of the Fermi model was prone to estimating large amounts of contrast agent transit for times smaller than the temporal resolution of the underlying data. The fact that reconstruction of transit time statistics beyond the time resolution of the data itself is ill-defined is represented by the essentially indistinguishable fit results coming from constrained and unconstrained Fermi response curves. For the segment shown here, application of the standard unconstrained Fermi model resulted in estimation of a 40% higher perfusion flow than the proposed constrained model, which was contradicted by the corresponding PET results. The final part of the results section is given by the review of two example cases. The first one being a patient 6 months after myocardial infarction following an occlusion of the proximal RCA. The highlighted inferior perfusion defect appeared as stress-inducible in PET, which would have led to a misclassification of the deficit as being indicative of a high-grade RCA stenosis. While invasive coronary angiography did not reveal a potential culprit stenosis, both the resting state DCE MRI exam as well as the LGE revealed an increased extracellular volume consistent with fibrotic tissue alterations. The second example case is a patient presenting with stable angina, significant left ventricular hypertrophy, but without any high-grade stenosis in either RCA or LAD at the time of the scan. PET data suggested classification as a case of apparent left ventricular cavity dilatation, however, lacking a true morphologic reference with respect to the dilatation. The latter is provided from simultaneously acquired MRI data, where DCE MRI revealed strong endo to epicardial perfusion gradients at stress concordant with microvascular disease and disproving an actual cavity dilatation. Summarizing the presented results, we have seen an overall concordance of myocardial perfusion flow estimates from simultaneously obtained NH3-Amonia PET and DCE MRI data. However, MRI overestimates PET blood flow and underestimates MPR when assuming equal arterial and tissue hematocrit. The projection of differences between plasma flow and blood flow onto tissue hematocrit resulted in significantly different tissue hematocrit estimates between rest and vasodilator stress. The so-derived correction factors for plasma to blood flow conversion of DCE MRI data are potentially relevant to all imaging methods using plasma-bound agents. Additionally, we have found that neglecting systematic limitations of DCE MRI deconvolution modeling, as shown for the unconstrained Fermi model, in the regime of small transit times may result in significant quantification errors as compared to PET. Therefore, we have proposed physiologically motivated stabilizations of Fermi deconvolution in analogy to previously described approaches for other models. Finally, I would like to thank you all for your attention, and I hope this video was helpful. I'm indebted to a number of colleagues from the Nuclear Medicine Department of TU Munich, additionally also from the Cardiology Department from TU Munich, and of course to my PhD supervisor Axel Hase and Andrew Arai of the National Institutes of Health. Thank you.